Would like to thank Dr. Yogesh Sastry for giving this opportunity, and I'm going to talk EUS guided FNN biopsy technique, how to get the best sample. It is very difficult to cover the entire topic in 15 minutes, but I'm going to highlight few points which will be useful for the beginners to get the good tissue sample and to increase the diagnostic yield. I always feel that we should answer the question which is required from the particular EUS examination. So rather than giving the very detailed report, if you answer the question which is needed from that particular EUS examination, that complete the EUS examination. And the aim of EUS FN, FNB is to achieve a diagnostic accuracy of more than 90%. What is the best sample? Which is cellular, least bloody and adequate in quantity. If any one of is missing, then your sample is not best. So it is important. A good EUS FNA should be cellular, less bloody and adequate in quantity. This is a photograph of an EUS needle. I'm not going into the details, but each component has its importance. That is stylet. This is a screw for adjusting the sheath. This is the screw for making the needle to and fro. This is the sheath and this is the needle. Each component has its own importance. I'm not going to discuss in detail. But yes, there are various kinds of EUS needle available in the market by various companies. While doing the FN, it is very difficult to opt that which is the good needle. But with the available literature, I'm going to guide you which needles are better, which needle should be used in what circumstances, so you can get an adequate sample. The needle size are available in 22, 25, and 19G. They are made up of stainless steel, cobalt, chromium, or nitinol. And they have a various tip design like lancet, mahogany, francine. And the sheath is also made up of a plastic or resin or a metal. So the most important thing while choosing the needle and the needle chip geometry is also very important. And which is more important, especially while taking the biopsy. Some needles has 3 beveled and some needle might have a 6 edges or beveled, and some needles has longer bevel and the smaller bevel, and that is going to help us in penetration of the needle. So, sheath design, yes, it matters. The metal sheath is better in comparison to plastic sheath. A sheath which has a spiral flexible sheath is better than the stiff plastic sheath. The nitinol needles are better in comparison to cobalt, chromium, or the stainless steel because nitinol needles has a memory as well as more flexibility and elasticity. The sonovisibility by using the laser cut, sandblasting, or dimpling, because needle should be very well visualized, and stylet has no significance. While doing the FNA, I think the lesion as well as location of lesion going to decide what kind of needle you are going to use. The suction versus stylet, how it is going to impact FNA, and the various sampling technique which I am going to discuss. When we talk about the needle, the most important, these are the various studies, randomized control trial comparing the 22 versus 25G needle. And these randomized control trial shows that there is no difference between the 25 and 22G needles. But this is a meta-analysis which shows 25G needle is better in the first and the second part of the duodenum, especially for the pancreatic lesion, where the scope is bent and it is difficult to take out the sheath as well as needle outside the scope. The location also determine which type of needle should be used. Like in the stomach and the esophagus, which is the scope is straight, you can use any needle and you can get very good results. While in the duodenum, as the scope is bent, it is difficult to take out the sheath and there is a lot of resistance while passing the to and fro movement. So it is better to use the more flexible needle, like or the needle which is thin like 25G needle or the nitinol needle, or when you are using the 19G needle, it is better to use the flex needle, which is made up of nitinol, and help in taking out from the scope will be easy. So the flexible and thin needle are better in the duodenum. while in the esophagus and stomach, you can use any kind of needle. Now, the appropriate choice of the needle, how it is going to impact your FNA, which is I'm going to show you by this study, which is published in GI Endoscopy 2013. And what they have shown that the 22G needle is good in the esophagus, stomach, and the transrectal. While using the transdural, you use the 25G needles. And for interventional procedure, standard 19G needle is okay in the stomach, esophagus, or the rectal. But in the duodenum, when you use it, is better to use the flex 19G needle by the Boston. And they compare the efficiency between the phase 1, where the any needle which was given to the operator they have used, while in the phase 2, according to this diagnostic algorithm they have used, and what they have seen that the technical failure was very less in the phase 2, where the needle was used according to the diagnostic algorithm. The choice of needle, so the most excuse me, the commonly used needle is 22G needle. 25G needles, as they are more flexible, they are smaller in size and the less bloody sample and easier to penetration. So better to use than the transdural aspiration, small lesion or the vascular lesion. 19G needle, where you require a core tissue, especially for the lymphoma, autoimmune pancreatitis, or aspiration of cyst or the viscous content. Now, technical factor like suction versus stylet. The 3 randomized trial, which has shown that the diagnostic yield and the cellularity has no effect while using the suction, but the specimen will be more bloody, as well as more number of slides were prepared when you use the suction. So it is better you should not use the suction. Suction is only should be used when there is no diagnostic yield. So my take-home message, or what I do in my clinical practice, in the first pass I use without suction. If there is adequate material, continue with the same. If the material is paucicellular, then I use the suction. So the target is also going to decide if you are puncturing the necrotic lymph node or fibrotic lymph node, or subepithelial lesion, or the lesion which has a lot of desmoplastic reaction. It is better to use the suction. But if you are puncturing the malignancies or metastatic lymph node, it is better not to use the suction. If you don't have a histopathological needle, and if you have a FNA needles, so for getting the core tissue, you can use the suction, which can be used for the immunohistochemistry, microcourse, or more for the molecular testing. This is a very elegant study published in 2017 by Bang et al., and where they compared the 22 and 25G needle with the suction and no suction, and what they have seen that 22G needle with the suction has the worst. The diagnostic accuracy is less in comparison to non-suction, or while applying the suction in 25G needle. Stylet, again, using the stylet produce more bloody sample, so it is better we should not use the stylet. Now, various sampling technique. The most commonly used technique which I will suggest is the fanning technique. Rather than doing standard capillary, wet, and door knocking technique, I request my all colleagues, the fanning technique is very good and has a better yield. So this is a study again published in GI Endoscopy 2013. And what they have shown that fanning technique, the first pass accuracy is 85% in comparison to standard, where the diagnostic accuracy was 57%. And what do you mean by fanning technique? In fanning technique, you start from the one edge of the lesion, either from the left or right, and you go up to the opposite side of the lesion. And each side, you puncture 2 to 3 times, so you can scan the entire area, and you do around 15 to 20 jabs. So fanning technique give the representation of the entire tissue. The capillary technique, there are the only few studies, and what they have compared that the standard of the capillary technique, not much of the difference. There's the only difference is with the 25G needles. But yes, capillary technique can be used. That is also possible. There is no comparison between the capillary versus the standard using the negative suction. This is the only randomized control trial. The wet suction technique, this is again a single study where they have seen that the wet suction is better in comparison to the conventional suction. But we require more data. Now, the another question comes, once you are inside the lesion, how many jabs to be done to get the adequate sample. And this is the study which is present in the abstract form in the DDW, and they have shown that around 12 to 15 jabs are sufficient. If you do more jab, you will get more bloody sample. And in each direction, you do 2 to 3 jabs. So you scan the entire lesion by passing in all the 4 directions, and you give around 15 jabs. So you get the cellular, less bloody specimen, and the diagnostic yield is better. Now, many of the time when there is no on-site cytopathologist, then how many passes you should do get the better results? For the lymph node, it has shown that the 3 passes are sufficient, but for the pancreas, around 7 passes has been recommended. If there is no on-site cytopathologist, if you have a ROSE, then yes, once you get the positive result, you can stop it. But after 3 passes in the lymph node and after 7 passes in the pancreas, the diagnostic yield doesn't increases. There is any role of repeat FNA if you get the negative sample in the first pass? Yes. 3 elegant study where the first pass was negative in the pancreatic masses, but repeating the EUS guided FNA increases diagnostic accuracy from 61 to 84%. So if you get a negative sample in the first pass, don't dishearten, don't subject the patient for the interventional radiologist. You can repeat the EUS FNA after a few days. The experience of the endosonographer definitely has a lot of difference. Less than 300 FNA per year versus more than 300. The diagnostic yield is more in the places where the more than 300 FNA was done. Presence of the ROSE increases the diagnostic accuracy by 10 to 15%. So if you have a facilities, then yes, definitely use the ROSE, but it is more prevalent in the European and the US countries. Now, once you get the sample, it is very important to adequately send the sample to the cytology lab. If you have not procured the sample nicely, then yes, you will not get the positive results. So for the slides, it is very important to make the slides by baking a sandwich technique. Don't crush the sample, and both use the air dry as well as wet fixation dry. Air dry is mainly used for the ROSE as well as by using the Diffquick method or for MGG stain, which give the intracytoplasmic and extracellular substance, while the wet should be done with the 95% ethanol and generally used for HNE or papinocular stain, which give the very good nuclear details. But make sure that when you are using the wet fixation, you should put inside the alcohol before the slides dry up. So what is the drawback with an FNA? Why there's a trend towards the FNB? The reason is that FNA has a negative results in the lymph node up to the tune of 10%. There's the elegant French studies, while in the patient of chronic pancreatitis with the cancer, the negativity result up to the tune of 50%. Many of the time, you may require the immunohistochemistry that require a micro course or the cell block, or you may require the tissue architecture detail, especially for the benign disease, or in the Asian countries where the tuberculosis is common, you may require a lot of sample for the gene expert or TB PCR for the culture sensitivity, or for the genetic testing, the FNAC material in alone is not sufficient. So what you require is a core biopsy. Core biopsy, initially it was thought that the more tissue, that is in the form of cell block. The cell block and the core biopsy are different. This is important. The cell block is made from the cytology needles, which is make a clump by centrifugation and you send it for the histopathological examination. But the core biopsy needle, you get the microcore, which is directly subjected for the histopathological examination. And why it is important? Because in pancreatic carcinoma, it is not just a pancreatic cancer. You look for the tumor and the stroma, and depending upon the stroma and the tumor, you can prognosticate the patient that this patient will be responsible for the chemoradiotherapy or not. So for the personalized treatment for pancreatic cancer or various other cancers, or for the benign disease, you require a histopathological specimen. Various FNB needles are available in the market. That is the 19G beveled needle or the 19G flex needle, Sile beveled EcoTrip Procore or 20G Procores by the Cook. Francine or the crown tip needles are acquired by the Boston. Shawcor or the 4-core tip needle by the Medtronics. Now these are the various photographs. And which needle is superior? Yes, the literature is available. Which needle is superior, which I am going to talk in the subsequent slides. So diagnostic performance of FNB needle, when we talk the 22G core needle, the adequate histology in 80% of the cases, but studies have shown that there is no advantage over the FNA needle. It only decreases the number of passes. While the Francine in the shark core needle, you get the adequate histological material in 90% of the cases, and there's the fewer passes are required. The comparative data between the FNB needles is sparse, but both shark core and the Francine needle has a better than the reverse beveled, that is a pro core, as well as large bore 19G needle. Shark core and the Francine needle, there is an equal histological tissue, which has shown in various studies. So the core tissue, which is a whitish tissue, you can do the micro dissection and you can send for the histological examination. And this is the blood, which can be sent for the cell block examination. The advantage of the core biopsies, you have a maintained tissue architecture, easier interpretation than cytology. Presence of the tissue stroma will be known. Cellular detail more clear than the usual cell block or the cytology. Better for the ISC marker, better for the Ki67 and for the mitotic counts. I think I have already discussed Procore versus FNA needle. There is no difference except the number of passes are less in the Procore needle. So as I discussed, in the histopathology, you will get the course and you send for the histopathological examination, which give the tissue architecture, which is used for the personalized treatment. Now, this is very important. Those who are beginners, while doing the FNA, as I said, it is not only the technique, but processing of the sample and the interpretation by the pathologist or the cytopathologist is important. So this is a European study where the first phase, the sensitivity was only 38%, but when they changed the lab where the dedicated cytopathologist was there, the sensitivity increased by the same performer to 91%. So it is very important. You should always discuss with your cytopathologist and give them the idea what you are doing, from which route you are puncturing. And cytopathologists can interpret the cytopathological slides better in comparison to histopathological specimen. This is a video which I have taken from the net for the biopsy from the cyst. These are the microcore biopsies, Maurice biopsy with the name, which is useful for the pancreatic cystic lesion, which goes through the 19G needles. So this is the Maurice or microbiopsy forceps, which goes through the 19G needle. You puncture the cyst through the routine 19G needle and you pass the biopsy forceps through this, which is clearly visible in endoscopic ultrasound image. And you can take the biopsy from the cyst wall, which help in the differential diagnosis of the cystic lesion of the pancreas. I don't have a personal experience about this. So ladies and gentlemen, to summarize, it is very important while doing the EUS, you should address the question which is asked. Your diagnostic accuracy should be more than 95%. If the rose is there, then FNA is preferable. If there's a no rose, FNB. But yes, in Asian countries, I think the rose is not available. Then you do at least 3 passes with an FNA, and FNB try to use the core biopsy needles. If you get a non-diagnostic cases, then repeat the sample, standardize the specimen processing, which I have discussed, which is very important. It is very important to get the good results as till you have a number of passes more than 300 cases per year. The conventionally, the 22G needle is better, but in special circumstances like transduodenal as well as vascular, you use a 25G needle. If you want a therapeutic cases through the transduodenal route, then it is important to use the flex needle by the Boston, although it is very costly. Avoid using suction, no role of stylet. Fanning technique is the best technique in comparison to the rest of the technique. And the specialized needles, the most important advantage is, as I said, it is more useful for the benign disease like autoimmune pancreatitis or GIST or patient with a neuroendocrine tumor, or where you require a personalized treatment, where you can use the FNB needle which is made up of nitinol. They have a memories and they are better elasticity and better flexibility. Thank you for the patience hearing. I will be very happy to answer if there is any question. Thank you for the patience.
Hello, ladies and gentlemen. Thank you for giving me this opportunity. Gentlemen, thank you for giving.
Dr. Rajesh, could you, Dr. Rajesh, could you tell us what are the most frequently or your preferred needles which you use in your practice? Which particular companies or?
Chawla?
Hi. Yeah. What are the most commonly used needles which you use in your practice? Which companies
It's
are?
a very good question. It's a very good question, and I would like to say, in my practice, gauge-wise, I use 22 gauge needle, and most of the time I use the FNB needle
Exactly.
rather than FNA needle.
Right, right. Probably
I
because,
send the sample both for cytology as well as for histological examination. This is my preference, and in therapeutic cases, prefer to use the 19G needle and transjugular route, as the flex needles are costly. I again use the 22G needle FNB.
okay. So, unfortunately, we are, number one, we are still running short of time, and we were not, we have some technical issues for the presentation. Of course, there was a great presentation by Dr. Sham, EUS Cadet Management of Pancreatic Fluid Collections. So, we were not able to put it on the agenda today. And so we'll be shifting to the next topic, and speaker will be introduced to you by Dr. Gaurav.
All right.